Most of the time, as I said, the insulin, what are the education we should give? Insulin techniques, hypoglycemia awareness, and the glucometer techniques. Most of them are insulin naves. So what I do personally in my practice is, see, most of the hospitals we still use the insulin vials. But on day 3, I try to start them with the pens, so that the patient himself or the attender has the knowledge of checking the glucometer, and we check that whether the techniques are good. So this is one advantage we should use when the patient is in the hospital.
Yeah, and especially if the patient has been not on insulin previously and is initiated in the hospital, patient must be trained on insulin administration technique before discharge. That is a part which is mostly missing.
Yes, and most of the hospital where the CIPG is done, we have a dietitian, diet educator, especially a person who has knowledge about the insulin technique. So that's the one advantage we have.
Right. So the last case, another interesting case, a case of NODAT. Dr. Mayura from Aurangabad is going to take up this case for us. So you have a 50-year-old male, underwent a right kidney transplant 5 months ago, no previous history of diabetes prior to the kidney transplant. Presently, the individual is on tacrolimus 1 milligram twice daily and omnacotil 5 milligram once daily. So now the patient is referred to the diabetologist with NODAT, fasting 322, postprandial 410, A1Cs 13, worsening of creatinine from 1.2 to 1.5. So when should insulin therapy be initiated? This is the first question in a case of NODAT.
Yes, if you talk about this patient, I would immediately start insulin therapy, obviously. But on an average, whenever a patient of NODAT will come, I will not really think of any other therapy. I would think of only insulin, because that is going to prevent probably the later on NODAT, which is, or insulin dependency which is there, which it will be prevented. So as soon as the hyperglycemia is detected in the post-transplant period, insulin, especially basal insulin, should be started, because insulin will prevent glycemia control, will obviously prevent multiple infections, and there will be early easy titration of the dose, obviously, because oral antidiabetics we won't be able to titrate. There are less chances of hypoglycemia because of that, and certainly less glycemic variability. So graft will be protected from the glycemic variability.
So what about the benefits of using an early basal
So there is
insulin?
one study when it's around 10 years ago, and they had used isofen insulin in NODAT when the NODAT was detected around 3 months of post-transplant. And it was shown that after 1 year, those who received basal insulin as compared to prandial insulin or oral antidiabetic drug, there was reduced need of insulin, rather there was insulin independence was there after 1 year, as well as few patients reverted back to normalcy when they were treated with basal insulin, and even there was reduced need of oral antidiabetic agents. So basal insulin seems to be a must in case of NODAT.
So then what are the factors that should, help a clinician decide in choosing this insulin regime? Should it be a basal plus or basal bolus?
Yes. So truly speaking, whenever, first of all, I would always prefer basal bolus whenever possible, especially patient is 2 months, 3 months post-transplants. One important thing is that if the patient has developed hyperglycemia immediately after the transplant, then we may go for IV insulin. There are few studies, they have given IV insulin also, and later on, once the patient is stabilized, they have shifted to total calculation of the dose and then to basal bolus. But certainly timing of initiation will decide how to initiate the immunosuppressive regimen. So as we know, tacrolimus has got high chances of NODAT, causing NODAT as compared to cyclosporin. Sirolimus also has chances, but tacrolimus has been consistently shown in all the studies to be associated with NODAT with high frequency. So with that regimen, I will certainly give insulin. Patient factors, since if the patient is say 6 months, 12 months post-transplant and patient is coming from a remote area to me, and then I have to think about maybe if I can taper 1 dose of insulin, probably replacing with linagliptin or something like that. Concurrent medications, there are no as such, I would say, interactions of the immunosuppressive agents as with oral antidiabetic agents, but still I will see the azoles may be prescribed to prevent fungal infection, or so that may reduce the levels of sulfonylurea if you are using. But we have to think all the concurrent medications which can cause hypo or hyperglycemia and decide insulin dose accordingly. Graft functioning. So if the graft is not functioning really well, I will not think about anything else but only insulin. So that is why I feel this is the most important case for this insulin symposium, because here the role of insulin is very much.
True.
Graft function, then glycemic targets and lifestyle modification. So sometimes if the patient is following very good lifestyle modification and there is weight loss over 2 months, 3 months, and there I may change insulin regimen from maybe pre-mixed, from basal bolus to pre-mixed. We can think of. So.
Another tricky situation is, using these immunosuppressive agents like tacrolimus beyond the use of the steroids. So how does these immunosuppressants impact the insulin requirement in the patient?
Yes, basically tacrolimus will reduce the beta cell density, and that is why it will reduce the insulin secretion. It also has got effect on the glucokinase. So glucose mediated insulin release will be inhibited. It will increase insulin resistance by decreasing the GLUT4 receptors which are there in the muscles as well as the adipocytes. Again, insulin phosphorylation signaling pathways will be impacted, and it may induce hypoglycemia, tacrolimus, and hypoglycemia associated diabetes can be, contribution to the diabetes will be seen. This is you can see in a graphical presentation. So steroids are the first drug, but in this case steroid dose was very minimal. So I feel it was just 5 milligram. So more of tacrolimus induced diabetes NODAT was there in this case. And sirolimus, mTOR inhibitors will also contribute to NODAT.
Yeah.
This is again, it is reversal. If we reduce these all immunosuppressive agents causing NODAT, there might be reversal to the normal beta cell, which has shown in few studies.
Okay, so what are the challenges in balancing this glycemic control with the risk of rejection, weighing that on the weighing scale?
So if we, first of all, if we reduce the dose of immunosuppressive agents, the major risk is risk of rejection.
Yes.
More immunosuppression, there is risk of, say, fungal, viral, bacterial, parasitic, all the infections. So risk of polymicrobial infection is there. More immunosuppression or infection, there will be aggravation of hyperglycemia. This again will lead to multiple more infection or severe infections. So this is a vicious cycle. And there will be hypoglycemia risk if we reduce the dose of, say, steroids. If there might be some sudden hypoglycemia, so there is always hypoglycemia risk in this patient. So certainly this is a very difficult task, I would say, to adjust the dosages.
So monitoring being the key, do you see a role of continuous glucose monitoring in managing NODAT?
Yes, though there are not very quite a lot studies, or there are no recommendation of use of CGM, but in hemodynamically stable patients, there is certainly role as we are using in other patients. There will be early detection of hyperglycemia, so we can prevent DKHSS or hypoglycemia in these patients. There will be less glycemic variability. It will be a personalized therapy. There are 2 studies about the use of CGM in NODAT. I mean, one study they have done CGM 2 weeks prior and 2 weeks after the transplant, and it was shown that the mean blood glucose, which pre-transplant, it was just you can say 119 plus or minus 14. They were associated with NODAT afterwards. Okay. It's just this much of blood glucose. So they had just high mean blood glucose, and the other group had 107 around, and post-transplant the group with NODAT had 160 milligram per deciliter. The other group had around 137. So this is one study. And another study, the CGM was applied for first 4 days post-transplant, and there were peaks of hyperglycemia, and those patients were detected to have NODAT after 6 months, 9 months, 12 months of post-transplant. So you can detect probably and prevent NODAT if we put CGM in post-transplant patient or even pre-transplant, but still we need more robust data for that. Another important thing I want to mention that the role of HbA1c.
Yes.
So HbA1c may not be the gold standard in NODAT patient, because if you think about kidney transplant, there will be, the turnover will be of RBC different, so you cannot really rely on, it will be underestimation. Along with maybe if you talk about hepatic transplant, liver transplant, there will be congestion of the spleen, and again RBC circulation will be hampered. Okay. So HbA1c may not detect properly the NODAT, so we have to rely on our routine blood glucose monitoring venous, but still since we cannot, HbA1c cannot be relied upon, we may, the CGM may have role in future. So we should have some studies on that.
Absolutely, that's a very important point. So just to avoid rejection, the immunosuppressant agents needs to be titrated, dose increased and decreased. So keeping in sync with that, how should the insulin regime be adjusted over a period of time?
Yes. So first, monitoring of blood glucose levels. This is very important. According to, I usually advise 6 point profile at least. So 6 point profile gives me precise answer once a week, 6 point profile. Or if possible, at least 4, not possible, at least 4 point profile, fasting and after meals. Then again, adjusting insulin regimen based on immunosuppressive therapy. We just discussed the steroids. So we are using intermediate acting steroids in case of transplant. So maybe the morning dose of insulin may be more required if we are giving intermediate acting insulin. Then again, timing of insulin administration will also, I will also depend on combination therapy. Yeah. So in few patients, what I have done, those who are coming from remote places, so I have given basal bolus combination. So maybe a lunch dose of insulin I have skipped, and I have used linagliptin in those patients. So it is given good results to me. And later on, maybe after 3 months, 6 months, or achieving very good control, and after that, once creatinine is stabilized, the eGFR is fine, no infection, then maybe from bolus insulin, I sometimes switch over to sulfonylurea metformin combination if possible. But this is very, if the clinical condition permits, obviously. Otherwise, basal bolus is the gold standard, I feel. And certainly patient education. If the patient is ready, so I would prefer again insulin in these patients.
Right, so that brings us to the end of the 4 interesting case, and we'll now open the house for discussions. We had a case of GDM, a case of steroid-induced hyperglycemia, and inpatient setting management of hyperglycemia using insulin, and a case of NODAT. So any quick comments, questions, first of all, from the audience about each of these cases to our panelists?
First of all, thank you very much. I think all the cases were very interesting, and you raised very, very important, pertinent points. Yeah. And all the panelists did a wonderful job. So a big round of applause for all of you. Now, I'd just like to raise one point. It is a question and opinion of all of you, and maybe a note. How prudent is it to use CGM in inpatient settings? We understand CGM is good for monitoring the trend, sometimes in type 1 diabetes for the insulin doses. But how good is it? Are there studies recommending the use of CGM in hospital patient?
You want to take that, please?
So practically, if we see that there are advantages of CGM over the glucometers in the hospital, in diabetes per se, but there are not many studies, and per se, practically it is sometimes, it is difficult for the nurses to, for us to educate the nurses. I think that is one of the point where we are lacking in convincing the hospitals to start the CGM on a day-to-day basis.
Actually, this is the reason I bought.
Can I, Amit, please? So I have been using, not in all patients, but infrequently. So first of all, I'm not using in ICU patients, those who are hemodynamically compromised. But otherwise, I'm using in many patients, and I'm satisfied. Only things the first 48 hours, 36 to 48 hours, there is low levels are shown, and even at the end, so that may be the problem. Second thing, in elderly patients also above 70 years with skin lag, which is there, so the contact may not be good. There I'm finding little bit discrepancy. But from day 2 to day 12, I'm finding them okay. But if you talk about comparing to the CGM of this Abbott Libre, I have used, fortunately, Guardian Connect in few patients, and it has given very good results. I was very satisfied. It's not available for us to use, but Guardian Connect 6 days I've used in few ICU patients also, on ventilator patients also, and I was very satisfied. Somehow I couldn't, because of non-availability, I couldn't use them later. But yes, stable patients, yes, you can use because...
Exactly. This is what I wanted the point that I want to bring up, that CGM is good only for stable patients. CGM is not good when there are rapid fluctuations. Either the glucose may be increasing or the glucose levels may be decreasing. Not just the glucose levels, even at the time of hypoglycemia or after hypoglycemia, when the glucose uptake at the cellular level is increasing. So CGM is not at all good. It is not recommended for monitoring glucose in such patients. So I don't know if there are any recommendations of using CGM.
Rajesh, it's a very good point you raised, and if some of us recollect, I think Dr. Rakesh was also there in ATTD this year. There was a whole symposium on the use of CGM in hospital setting. And the whole summary of it is, the limitations of using CGM is in the ICU setting, is if the patient has got hypotension, hypoperfusion, dyselectrolytemia, because all that kind of going to interact with which you just said.
And that all actually happens in ICU.
Yeah, so that happens in the ICU, and yes, it can be fairly used in the ward. But the rationality is, and that's where the consensus is coming from the European side about using CGM, leaving aside the cost. For them, it's not the cost. For us, it's the cost. It is sort of insurance driven in their countries. The rationality is, by using CGM, you can minimize the incidences of unwanted hypoglycemia or unmonitored hypoglycemia, which is far more, improving the quality of the life of the individual during the hospital stay than these errors. Because what they're recommending is you can use CGM and you can always cross-verify it with your glucometer. So there's still a lot of gray and consensus coming out over that.
That's very true. And one thing I want to point out here is that you're talking about Guardian and Libre Pro. Now the issue was at that time that the Libre Pro takes reading every 15 minutes. And Guardian was the nearest because that is taking one reading every 5 minutes. So at that time, there were some hospitals who were using Guardian sensor, even in the ICUs, even though it is not recommended, then that made sense. But now we have this Libre sensor, which is taking one reading every 3 minutes.
I was talking about Libre only, not Libre Pro.
So thank you. So thank you very much. I guess that brings us to the end of this session. And now I'll request everyone to get ready for the inauguration. Thank you to all our panelists. Thank you very much.
Thank you, everyone.
Now we are ready for inauguration. In just next 5 minutes, we are arranging that. And we will be starting our inauguration. Very short, nothing very hi-fi about the inauguration. But thereafter, we have orations, 2 orations, and followed by a keynote address. So that will be very interesting, and all will be in this particular hall. So please be seated, and we are just arranging for the inauguration. Joining us for the inauguration, and first and foremost, at the outset, I would like to thank everyone, whoever has joined for this particular conference. I hope you all enjoying it, because the deliberation has been great, and we have a faculties par excellence, so obviously it was expected as well. So it's a very short inauguration. What I am going to do is I'm going to invite few of our guests on stage. We would like to felicitate them with a bouquet, and then we do a lamp lighting ceremony. So I'll invite Dr. Vasant Kumar to come on the stage. Dr. Rakesh sir, Dr. Jayant Panda sir, Dr. Vijay Viswanathan sir, Dr. Meena Chabra, and Dr. Lily Rodriguez. Please come on the stage. And please accept just a small token of love from all of us. Okay, so we can have a group photo if you want. In one line, please. Can you stand in front? We have a group photo. So we want to make it very informal. We don't want to have that extravaganza inauguration which we see in almost all the events. So it's straightforward, simple stuff. I know we have missed out lots of there, but definitely we'll do it. Thank you, sir. Thank you for coming and gracing this occasion. And now we are going to announce the name of the 3 winners for the best clinical case presentation. I hope they are here. And this was basically judged by Dr. Bhagirath Solanki, Dr. M. Sunmuga Velu, and Dr. Vinod Abhichandani. The first prize goes to Dr. Puranjoy Chakravarti. Dr. Silima, are you there? Dr. Silima, okay. So we have a representative, I think Puranjoy's wife. You can come up. So see, she was not there, but yeah, Dr. Puranjoy Chakravarti has won the first prize. I think there's a big kind of something out there, which is for the first prize. It's fine. Thank you. The second prize goes to Dr. Agnik Pal. Is he there? Please come. A big round of applause for Dr. Agnik Pal. And the third prize goes to Dr. Parag Rana. Thank you all for participating, and it was a wonderful session right in the morning, clinical presentations, and they were all good. There were 9 presenters, out of which 3 won the prize. Thank you. Thank you, sir and ma'am. So, just to give you an idea about what we planned out for this particular conference, the idea was that we had a theme that was metabolic health, bridging research and clinical practice. And the whole planning of the scientific agenda was around that. If you go through the agenda, we not only had a wholesome online content yesterday, which started from 12 in the noon till 7 in the evening. And there were 1,068 delegates attending that particular conference. So a big round of applause for all the delegates attended online. And we had 6 international speakers for that particular online conference, and rest of them were big shots from across India. Yesterday's program started at around 4 o'clock, and there were different aspects or different sessions. There were some theme talks, there were some mixed bags, and there were certain endo talks as well. Since morning, both the halls were there, and we had 2 theme talks, which were purely on the metabolic health, and then we had other talks on the diabetes and comorbid conditions. We had a lot of workshops, and the interesting part of workshops are that the moderator took keen interest in planning of the workshop, coordinating between the various presenters, and really came out with a useful and very successful workshops. So I thank all the moderators who took this, took the onus on actually planning out the workshop. And the workshops were on numerous aspects of metabolic health, basically. And to end up today, post-inauguration, we have not only some talks left, but we have 2 orations. One by our present President RSSDI, Dr. Rakesh Shah, who will be giving the RSSDI presidential oration, and that will be followed by the DRW oration, which will be given by Dr. Vasant Kumar. And to follow it up, we have keynote address by none other than Dr. Vijay Viswanathan. So thank you once again, and I think I leave it to I will request Dr. M.S. Anwarwala to give it a vote of thanks, small vote of thanks. He is the president of DRWA. So again, a big applause for him as well.
Good evening, and thank you all for participating in this annual conference of DRWA. We have tried our best to make your stay comfortable and impart knowledge through our various workshops and theme talks. I'd like to thank our sponsors who have stood by us throughout these years, and without whose support we would really never be able to organize a conference of this scale. So thank you, sponsors. Thank you, all the delegates and all the faculties for coming all the way. Without the delegates and faculties and other members, ये गुलिस्तान खाली पड़ा रहता. Thank you very much.
Thank you, Dr. Patni. As you said earlier, probably I have been associated to DRWA since beginning, may not be initial few years, and I've seen that how this organization has grown up. Not only that, they have now spanned all over India. Initially, it was a small affair, and now it has grown up. And as Dr. Patni has said, that they had online program which was attended by thousands of delegates, and speakers were from overseas as well. So that is a good sign. And not only that, they are not only these conferences are organizing, they are also engaged in so many activities. I have seen organizing social activities, various educational activities throughout the year. That is a good thing. Any organization like DRWA should organize social activities as well as research activities. He has started so many things. So I will like to congratulate whole DRWA for all these achievements. Thank you. Thank you very much.
Good evening, friends. I am part of the family, and I am remembering every step how we have come forward from a small hall with a small gathering, how DRWA has started functioning. When I was associated, people like Narsingh Bammaji, Anuj Maheshwari ji, and the Lucknow team, and Dr. Bijay Patni and the whole group, Tamanash, Partho, and Sanirwal, and all team that you see here, they had a plan, and we have moved across the years to the 11th conference. And you know, for last 2 years it's in the Bishwa Bangla, one of the largest convention in the East India, and there we are celebrating the science with multiple halls, paper presentations, exhibition, and 3 days long program. This conference, I was there in the online program, excellent deliberations. I myself got wiser by listening to the speakers. Since morning, I am there around listening and interacting, and I'll be there for the oration of stalwarts like Rakesh, Bijay and Bashanji. And I'm happy. Today you see who's who of the country. All the states are represented. Like any national event, everybody here. And I'll end with an event in the Odisha group when I put DRWA program, the details. One new doctor asked what is DRWA, and before I tell something, people replied from their side, it's Diabetes Research and Welfare Association. So that is the recognition that in Odisha, everybody understands what DRWA is, and in Bengal, it's a landmark event, it's a flagship event, and it has got a national recognition with an annual event every time. So I congratulate Dr. Bijay Patni for his single-handed effort and the whole team who are there with Dr. Patni taking it forward. We are there committed, and I thank the whole national team who have come forward with such a informative, rich, scientific program, and I'm sure we can go a long way together taking DRWA as our forum. Thank you all.
So without wasting much of a time, we will start on the first oration. The first oration is RSSDI Presidential Oration. Soon after the oration, we are going to felicitate the orator, and that's the way we go about. And the oration will be chaired by Professor Swati Srivastava, Dr. Pratap Jethwani, and Dr. Partha Vishwas. I will request them to come on the stage. Actually, what we do is basically we read out the citation right at up front, but we want Dr. Rakesh Sai first to speak on the oration, and thereafter we are going to do the necessary formality. So Dr. Rakesh Sai, sir, need no introduction. He is the RSSDI president, and obviously is going to speak on this RSSDI presidential oration, and he will say on a very important topic, navigating the first year in diabetes diagnosis and management. Sir, please come on the stage, sir.
So good evening to all of you. Thank you to DRWA and Dr. Bijay Patni for inviting me to be here today. Going with the theme of the conference, which is saying metabolic health, bridging research and clinical practice, I thought an appropriate title for the oration would be, first year of diabetes, why it matters and how to make it matter for people with diabetes. So that is what I'm going to discuss today. So I don't have any conflicts of interest, but I'll start off with, two case scenarios which are patients all of us see. This patient would have walked into all of your, all of you can recall such a patient coming to your clinic, a 30-year-old gentleman who's a IT professional working on a US-based timing. He's working from 9 p.m. and works till 3 a.m. in the morning, eats snacks a little bit in the night, and he goes for an annual checkup, and he realizes that he's overweight, or obese rather. You could not even call him overweight. He's obese and he has got sedentary habits. He's got a blood pressure which is again striking a bell. I mean, looking alarming to us. For him, it may be looking quite okay, and his blood pressure, glucose values, as you can see, his HbA1c is 10.4, his lipid levels are deranged. Looking at all this, we are all worried. He's quite comfortable. He's asymptomatic. He is wondering why we are so much worried and giving him so many medications. Looking at all the guidelines, we are saying that we should use 3 medicines and whatnot, and he's really confused why this doctor is doing this, and he goes to another doctor and probably he meets 1 or 2 more doctors and then stops doing anything till he comes back again after 2-3 years to you. So that is what the scenario is, and you may either advise, some of us may give him a lifestyle advice and say that you come back after a year. Some people may initiate him on insulin, metformin, DAPA, Sita and all that. Some people may put him on insulin. That's a good way of treating him. Some people may just use metformin. So I'm not going to take a poll on this right now, but I'll just discuss about these aspects. And similarly, another lady who's again has a similar background. She's been gaining weight, and she's again detected to have diabetes, but is advised lifestyle measures, metformin, but she doesn't want to take that also. She's worried about taking medicines because of taking the medicine, she'll have to take medicine always. That's the concern that she has, and she doesn't want to take it all. So she doesn't come back for follow-up. So these are, I'm sure all of you have seen patients like this coming to your clinic, and what should be the approach to that is what I wanted to cover in this today. So if you look at people with, we look at the global scenario of diabetes. We are all aware of that diabetes is growing by leaps and bounds, and we have a significant morbidity because of diabetes. We can say that in 2019 the WHO reported that there were 1.5 million deaths because of diabetes, and 48% occurred before the age of 70 years. And DKD was another important cause of death, contributing to 2 million deaths. Hyperglycemia causes about 20% of the deaths are because of cardiovascular deaths are because of hyperglycemia. So we all know this. We all know that the burden of diabetes. The recent INDIAB data has shown us that we have a huge burden of diabetes in our country itself. We have 11.4% prevalence of diabetes in adults, and that translates to about 100 million people with diabetes, 101 million people to be precise, and we have a prevalence of 15.3% for pre-diabetes, again going to 136 million. But the sad part is that most of them do not know that they have diabetes, and those who do know, just like these 2 patients who came to us, they don't want to start off treatment, they don't want to take treatment, effective management. So that's the reason why we see that there's a huge amount of work to be done. We need to educate people about the importance of managing diabetes well in the first year of diabetes. That's what I wanted to highlight the fact that diabetes is not a simple disease. It has a lot of complications. We are all aware of that apart from the microvascular disease, macrovascular complications are the major cause of morbidity and mortality, and they are becoming the leading cause of all the problems, whether you look at blindness or whether you look at renal disease, end-stage renal disease. Diabetes has become the most common cause of that. Whether you look at non-traumatic amputations, again diabetes has become the commonest cause for that. And we also know that there is a sort of close interaction between these complications. Whether you look at the microvascular complications, they closely correlate with macrovascular disease. Dr. Rajiv Chawla, would be working. He works on these correlation of these complications, and he shows that these complications correlate. And we also know that those with CKD have a multiplication of the cardiovascular risk, and those who do not have ASCVD also are at very high risk of heart failure. So I think all these are correlated, and we know that there is a huge burden of the major burden of diabetes because of its complications, and our objective should be to prevent these complications. And we know that the various factors that are coming into play, which are contributing to the diabetes hyperglycemia itself. It's gone beyond the defects in insulin secretion and insulin resistance itself. We have understood all the other mechanisms that are contributing towards hyperglycemia, and we have tools for that. Today we have tools for correcting the renal reabsorption of glucose, increased renal reabsorption of glucose. Whether you look at the incretin defects, we have very good agents to tackle each of these defects, and we need to use them appropriately. But we also know that the beta cell failure is a very major factor which is contributing to the development of diabetes. And we know that we have a problem. If you look at our people with diabetes, we are different, with diabetes occurring at a younger age, at a lower BMI, and we tend to have more of abdominal fat, and all this contributes to increased insulin resistance and development of diabetes at a decade earlier. And as you can see, the unique Indian phenotype encompasses all this: lower age of diabetes onset, earlier beta cell decline, greater degree of abdominal obesity, greater insulin resistance. And because of this, we know that we are at higher risk of complications. The comorbidities and complications are much higher. If you look at the data which was shown by Professor Mohan's epidemiological work, we showed that the prevalence of complications, he has shown that this was data from 2010. So I'm sure these numbers have gone up to more than double that, because at that time the prevalence of diabetes was somewhere like about we used to speak of 60 million or less than that also, in those days. And with doubling of the prevalence of diabetes, all these complications also have become much more. So what I wanted to show is that there is a point of inflection where the complications, once they start off, you have you getting them back to normal is very difficult. So it is important that we start early, diagnose diabetes early, and prevent these complications. And we have enough data to say that these complications can be prevented, and we can prevent the reduction in the lifespan, which is seen to the extent of about 6 to 14 years of life being lost because of diabetes. And this can be prevented if we are able to start early and prevent these complications. So early intensive therapy is the need of the hour. The first year of diabetes management is very pivotal in setting the trajectory for the long-term health outcomes. Early glycemic control, comprehensive education, lifestyle modifications, psychological support, and personalized care are very crucial to provide that benefit to our patients. And the efforts made during this period have lasting benefits, reducing the complications and enhancing the quality of life for people with diabetes. So this is what is important. And do we have data? Do we have any data to support this? We have data from the DCT study which showed that on the average you could reduce the complications by about 60% by 2% reduction in HbA1c, and the UKPDS study showed that we could do it to the tune of about 30% in all the microvascular, average reduction of about 30% in the microvascular complications by good glycemic control, by just a 1% reduction in glycemic control. And for many of those who are not aware of the UKPDS, because I realize that when I talk to my PGs, I realize that they are not aware about UKPDS. We think that everybody knows about UKPDS. So just for the younger members of the audience, I would say that UKPDS was a study which was done enrolling patients right from the onset of diabetes. In the 1970s it was started, and people with diabetes who walked into the clinics with 5,000 of them were enrolled, and they were randomized to either the conventional arm, which started medications if they had a fasting glucose of more than 270, which was considered till that time to be okay. And those in the intensive arm were treated to keep their glucose in the normal ranges, which was considered, it was at the end of 10 years they could bring about a difference in HbA1c of about 1%, 7% versus 8%, 7.9 you can say. Precisely it was a 0.9% reduction in HbA1c, and with that all this benefit was seen in 10 years of follow-up. So that was right at the onset of diabetes when they were enrolled in the study. This difference was seen. And the best part was that, after the 10 years, you had good evidence. Now there was a lot of evidence that, this good glycemic control makes a difference. So everybody did that. Everybody was advised that it was unethical to keep some people at a higher glucose level, and everybody was given the same advice, and all of them did the same. They maintained HbA1c of around 8%. So they couldn't do it as well as they did earlier, but they maintained it 8%. And after another 10 years, there was a benefit seen in the macrovascular complications also. Cardiovascular disease, which did not come down significantly in the first 10 years, came down, the difference was seen. And the other complications also continue to be at a lower rate, lower rate of, lower prevalence of all the other complications also. So as you can see, over 10 years, that was 30 years since the onset of their diabetes, you see that the good glycemic control achieved early in the natural history of diabetes had a long-lasting effect, and that was labeled as metabolic memory or a legacy effect. We say that, if you're able to provide this good glycemic control in the first year of diabetes, you are giving a good legacy to this patient. So much so was there for the UKPDS. But now the another interesting thing is that we have data on these same patients were followed up further, and now at 40 years from the time that they were first enrolled in the study, now we see that the recent publication of UKPDS, the UKPDS 91, which has patients who have followed up even beyond that last publication. You see that the group which were in the intensive treatment arm continue to have the benefit even now. Even after 40 years, you see that the early intensive glycemic control with sulfonylurea or insulin or with metformin compared with conventional glycemic control, that appears to confer a near lifelong reduced risk of death and myocardial infarction. So this clearly shows that this early initiation of treatment in the first year of diabetes made a difference for this group of people who were in the intensive arm, and they continue to have this benefit even after so many years now. The legacy that was given to them continues to protect them from the complications, and so therefore what is clearly understood from that is that achieving near normoglycemia immediately following diagnosis might be essential to minimize the lifetime risk of diabetes related complications to the greatest extent possible. So here you see the overall risk reductions that we've seen after almost 24 years. You have got 24 years of the completion of the first phase. So that is almost 34 years since the time they were enrolled in the study. So death from any cause 10%, myocardial infarction 17% reduction in myocardial infarction, 26% reduction in microvascular disease. So this was almost close to what was seen at the initial 10 years of the intensive treatment. Even now, after so many years, they are continuing to have that benefit, although their control is not so great as was happening in the first few years. So in spite of that, they continue to benefit from the early intensive treatment that they received. And if you look at the death from any cause also, that's down by 20%, myocardial infarctions down by 31%. So the separation of the Kaplan-Meier curves did not diminish over time, and the cumulative hazards ratio appear to remain constant over the several years of follow-up also. So this clearly shows that there is this benefit which they achieved with the early glycemic control is giving them lifelong benefits. And what we are seeing here is that their quality adjusted life years are also much better for those who were on the metformin treatment as compared to those who were on conventional glucose control, which was essentially lifestyle advice that was given at that point of time. So is that the only study that gives us that shows us that benefit, or is there anything more that is there? So if you look at this data from Professor Kamlesh Kunti's group, they have looked at people who could achieve a HbA1c of less than 7% in the first year compared to those who did not achieve the less than 7% in the first year, and they followed them up for 5 years, and what they found was that those who could not achieve that initial 7% HbA1c in the first year had at 5.3 years of follow-up had a significantly increased risk of MIs, 67% higher risk of MIs, strokes higher up by 51%, 64% increased risk of heart failure, and the composite cardiovascular outcome up by 62%. So clearly showing that the first year the control in the first year has a significant impact on the complications when you follow these patients over a period of time. So the dysglycemic legacy has initiates the complications and drives the risk for complications. And what is the scenario today across the world? We know we have data from India, we have different studies done at different points of time, and all of them show that just about 1/3 of the patients are achieving the glycemic goal of less than 7%. Is the data for the rest of the world different? Maybe in US today we hear that, the ADA says that probably about 50 to 60% of them are at that goal. But if you look at the worldwide data, global data, you say that only 17.4% are achieving this target of HbA1c of less than 7%. And if you look at those who are above 9%, it's to the tune of about 1/4 of them are at HbA1c of more than 9%. So clearly there is a lot to be done in terms of seeing that our patients understand the need for better glycemic control, because we have the tools today, but it is basically to see that we use them effectively and to motivate our patients to keep going with maintaining their glycemic goals. So there are several challenges in achieving these goals. It is on the part of our physician, on the part of us itself. We fail to adopt a treat to target approach many a times, and then there are medication related issues. Single agent is not able to, as we've seen, there are so many defects contributing to hyperglycemia. So a single agent may not be able to get us to the goal. So we often need to use combination therapies. And that adds to the burden. If you just imagine those two patients, they are worried about taking the first medication itself. They're worried about taking any medication itself, and then we say that you take 3 different pills. They are obviously not going to follow that. So we have many solutions to that. We have combination therapies, fixed dose combinations available. They are particularly useful in such scenarios because we are able to address different mechanisms by different pathophysiological defects by using a single tablet which has all these medications in it. And then there are patient-related concerns, as we said. There are concerns about adverse effects of medications, the costs of medication, the complexity of therapy. So all these challenges need to be addressed if we are to provide good glycemic benefit to our patients. And the other important aspect that is coming out is the young onset of diabetes. We just spoke about the fact that Indians in general have a earlier onset of diabetes, but globally also we are seeing that there's an increase in prevalence of young onset of diabetes. And at this point I would like to say our friend Dr. Rakesh Parikh is here, and he has worked hard in bringing out this publication from the data, analyzing the data from the Defeat Diabetes campaign, which we had conducted in 2021 by the RSSDI, which I'm sure all of you were part of that, where we tried to reach out to a large number of people. Dr. Vasant Kumar, who was the president at that time, is also here with us. So at that time we reached out through different mechanisms. We tried to reach out to more than 100 million people, and we culminated the whole campaign by doing 1 million tests on one particular day, that was 29th of September 2021. And although we could reach the target of doing 1 million tests, but the collection of data was appropriate for about 1/4 of them. That still was a big number. 235,000 data collected. After cleaning up the data, we still had analyzable data in the form of 225,000 population data was available to analyze. And what we understood from that is that diabetes, is occurring at younger ages. It's quite common, as you can see in this graph, and the gender distribution was almost about 63% of females and 37% of males were affected. And if you look at the prevalence rates of diabetes, you can see that the total prevalence in this population, however, there's some bias that this is a clinic level data. So we had about 44% prevalence of diabetes in the population that was looked at that point of time. But interestingly, what we found was that diabetes was very common in the younger population. If you look at less than 35 years, the prevalence was to the tune of 17.9%, less than 30 years, 13.3%, and less than 25 years also it was 9.8%. So what it shows is that we are our population is developing diabetes at a younger age, and even those at the less than 35 probably have the highest prevalence of diabetes in our population, and we need to address that effectively. We need to understand that we need to start screening early and give importance to the values that we get on screening these patients, because most of the time we do the screen test, but these people who are identified to have dysglycemia or hyperglycemia fail to follow up with proper treatment, and that's what makes a difference, and that is what is the whole message that I want to convey with this oration, is that we need to start screening early, identify those, particularly those who have a family history that had a higher prevalence as compared to those without a family history. But in spite of that, there is a significant prevalence even amongst those who did not have a family history. If you look at the under 35, the first bar, you see that although the prevalence was 40% in those who had a family history, even those who did not have a family history, it was 11.7%. That itself is quite significant. So that is something which we need to keep in mind, and use this information to screen more and more people, to detect their diabetes early, and to provide them better care and better in order to defeat diabetes, as the campaign was coined. And if you look at the data, not only this data, but if you look at the data of youth onset diabetes from the US study group, the Today study group, which was across many centers in the US. If you look at these young onset of type 2 diabetes, generally what happens is that we tend to treat them as a little more casually than those with type 1 diabetes. And so interestingly, if you see this analysis of this data, looking at the complication rates amongst those with type 2 diabetes and comparing them with type 1 diabetes, you find that, for the same age, macrovascular disease, 22% in these young onset type 2 diabetes versus 0% in type 1 diabetes. If you look at microvascular complications, 68% amongst these young onset type 2 diabetics as compared to 27% in type 1 diabetes. So this is a more malignant disease than type 1 diabetes. We need to address it more effectively in terms of preventing the complications, and the casual approach that our patients have may actually put them in at much higher risk of complications. So this is what we need to keep in mind, and we need to treat this, have a more aggressive treatment approach for these young onset type 2 diabetes compared to even the type 1 diabetes, because it doesn't mean that we should be complacent with our type 1 diabetes. We need to sort of treat them effectively, treat them adequately, but also we need to pay attention to these people with type 1 diabetes and the young people with type 1 diabetes. So this highlights the importance of first year of diabetes management, managing effectively diabetes in the first year of the onset of diabetes. So it lays the foundation for long-term health benefits. It establishes good healthy habits. It gives comprehensive. The patients get a comprehensive diabetes education. They understand. They get better psychological and emotional adjustments, and early and personalized interventions can be initiated. And this builds a strong relationship between the healthcare provider and the patient. So I think these are all the benefits that accrue from starting early, providing a good management for the diabetes in the first year. And today morning only I just borrowed this slide from Dr. Vijay Vishwanathan on the 100th centenary celebration of 100th birth anniversary of Professor M. Vishwanathan, who was the father of diabetes in India. He had said that every person having diabetes should be helped to live his normal lifespan, a normal span of life in perfect health, free of complications. So that is what we should all aim for, and that can be done only if we are managing our patients effectively right from the time of the onset of diabetes, so as to provide a good legacy to them. So what are the strategies for achieving good glycemic control? All of you are aware of this, apart from the non-pharmacological therapy, whether it is diet and exercise, use of medications effectively, whether it is, most of the time what we see is that, the traditional stepwise approach doesn't always get us to the goal. We are not able to get the patients to the glycemic targets, and they fail to sort of get the benefit of these stepwise approach, and hence we need to be more oriented towards providing a treat-to-target approach where we are able to use agents appropriately so as to get them to the target. And this is what most of the guidelines, whether we look at the RSSJ guidelines or whether you look at the ESD or ADA guidelines, all of them are speaking today of using early use of combination therapy right from the time of onset of diabetes. If the HbA1c is more than 1.5% above the target, you need to use more than one agent, and then only you will be able to get them to the goal that you're looking at.